Hello, everyone. Dr. Alex Vasquez here, coming to you today to discuss a clinical review of vitamin D deficiency in adults. This is part one, and here I'll focus on various pain conditions. So again, this is going to be part one of a series, this time focusing on pain conditions as part of a clinical review of vitamin D deficiency in adults. I think that this is an urgent topic, and I think that it's time for us to update and refresh our perception and paradigms regarding vitamin D deficiency in adults. I think this is of daily importance in clinical practice. This important condition remains tragically underdiagnosed, underprevented, and undertreated in roughly 60 to 90% of the worldwide population. We'll look at some basic sciences, and the question that I have from a basic science level is, where does vitamin D function at the cellular level? With regard to clinical sciences, my main question is, how does vitamin D deficiency contribute to disorders of chronic pain and inflammation? And my fifth focal point here is patient management. Describe the clinical presentation and management of vitamin D deficiency. Most of you know that in 2004 I published a major monograph on vitamin D, and you can download that from the academia website. As you can see here, this is a free PDF peer-reviewed article download. As I discuss vitamin D deficiency today, I want to stay within certain parameters that are established by the U.S. Food and Drug Administration, and these particularly apply if we're going to make what they consider to be any type of claim. This would be structure and function language, claims of general well-being, or claims related to nutritional deficiency disease, and any conversation around that must include prevalence. Anytime nutrition companies make a claim as defined by the US FDA, they have to submit notification within 30 days of first use, and they have to put a disclaimer on the label if they're attributing those benefits to a specific product. In this case, we are talking about vitamin D deficiency in adults. So the main summary is going to be presented on this slide. So we're going to look at this slide right now, and then we'll look at it again toward the end of the presentation. But what I want to focus on is diagnosis and management of vitamin D deficiency in adults. Subjective or historical components include risk factors such as dark skin, obesity, older age, malabsorption, inflammatory bowel disease, of course because of the inflammation and the malabsorption, sunlight deprivation or overprotection, and chronic use of anticonvulsants or prednisone derivatives, often called steroids or anti-inflammatory steroids. So anticonvulsants and prednisone derivatives upregulate the so-called detoxification pathways in the liver, and that actually promotes the excretion of vitamin D and its downstream metabolites. So those drugs directly contribute to vitamin D deficiency. Obviously, for those of you who are aware of vitamin D, you know that that's somewhat paradoxical or ironic, because a consequence of vitamin D deficiency is more inflammation and also seizures. We'll talk about that in just a moment. So the irony is that the medical treatment of those conditions actually can perpetuate vitamin D deficiency, which perpetuates those conditions. Moving on now to bone pain, muscle pain, fatigue, depression, infections, and also gastrointestinal dysbiosis. A more frequent history of falls, also cognitive impairment, and statin intolerance or statin-induced myalgia. All of those are known to be manifestations of low vitamin D status, or what we should call just vitamin D deficiency. So, for example, in the past, we used to distinguish between vitamin D deficiency and insufficiency. We should call all of it deficiency, and obviously some deficiencies are more grave than others. But rather than split hairs between deficiency and insufficiency, let's just call everybody deficient if they have less than 32 nanograms per milliliter or 80 nanomoles per liter. That's really the physiologic cutoff for vitamin D deficiency. I'll talk about all of that again here today and in some of the videos in the upcoming remainder of the series. And after today's introduction, focusing on pain, I'll also talk about depression and reduced immunity or increased vulnerability to infections. The most consistent objective finding of adult vitamin D deficiency is osteomalacia, which you can assess clinically by looking for pain at periosteal surfaces, and I'll discuss this more later. But what you want to do as a clinician is apply a modest but significant pressure at the radius, the tibia, and the sternum. Do not use the mastoid process and do not use the olecranon because those surfaces are famously insensitive. Global and symmetric muscle weakness in severe cases. So once you make the assessment, you can use a diagnosis code as I've listed here. You would really confirm the diagnosis based on laboratory testing, as you can see in the image here, and as I'll show you several times throughout today's presentation. And your clinical plan should be to treat and test virtually everyone, because we're talking about a condition that affects up to 95% of the global population, and I'll show you the statistics on that in just a moment. Follow-up includes monitoring labs and response to treatment, just like you do with everything else in clinical medicine. So, my basic science question is, where does vitamin D function at the cellular level? The answer to that question is at the nuclear receptor. So vitamin D actually docks onto a vitamin D receptor, a nuclear vitamin D receptor, which heterodimerizes with the retinoid X receptor. As a transcription factor, the vitamin D receptor upregulates or downregulates nearly 3,000 different genes or DNA docking sites. Vitamin D also modulates other transcription factors such as NF-kappa B, which, as most of you know by now, is absolutely critical for the transcription of hundreds of genes, especially those related to inflammation and immunity. So vitamin D, again, by interacting with the nuclear vitamin D receptor, directly affects almost 3,000 different DNA binding sites. Now, when you consider that vitamin D also modulates NF-kappa B, nuclear transcription factor kappa beta, and that transcription factor also modulates another several hundred or several thousand DNA docking sites, then you can truly see that vitamin D affects many, many very important systems within the human body. But that's not all. So the basic science question again that I'm asking is, where does vitamin D function at the cellular level? Most people who know about vitamin D would say the nuclear vitamin D receptor, but a lot of people wouldn't know about the membrane receptor for vitamin D. So this is called the MEM-VDR or the VDR-MEM. This is a non-genomic rapid response receptor which amplifies the effects of vitamin D through second messengers, including inositol triphosphate, protein kinase A, and cyclic AMP. So basically with vitamin D, we see changes in nuclear transcription, and we also see rapid response changes at the level of the cell membrane. Vitamin D has daily importance in clinical practice. This important condition of vitamin D deficiency remains tragically underdiagnosed, underprevented, and undertreated in roughly 60 to 90% of the worldwide population. And here I'll show you an excerpt from the monograph that I published in 2004, which again, you can download for free online. So let's look at some of the prevalences that I documented 17 years ago for vitamin D in various populations. 57% of 290 medical inpatients. As I recall, that was published in the New England Journal of Medicine. Another study found 93% of 150 patients with chronic musculoskeletal pain in the United States, 48% of patients with multiple sclerosis, 50% of patients with fibromyalgia, 42% of healthy adolescents and African American women, and at least 62% of the morbidly obese. Other studies showed deficiency among 83%, 73%, 58%, more than 40%, and 40 to 70% of Scandinavian medical patients. If we look at a more recent publication, this time from Journal of Steroid Biochemistry and Molecular Biology, 2014, we see that with a reasonable definition of vitamin D deficiency, in the United States, 34 to 37% of people are deficient. In Canada, being farther north, that prevalence goes up to 60%. If we look at Great Britain, the incidence in winter is as high as 87% and in summer at 61%. In Scotland, Norway, Finland, we see prevalences of 52%, 65%, 77%, and 78%. If we look at New Zealand, we look at prevalences of 90% in men and approximately 90% in women as well. Australia, 73%. The most common manifestations of vitamin D deficiency in adults are depression, infection, and today's topic, which is chronic pain. So in 2004, we documented in our review article that vitamin D deficiency was prevalent in most populations, and here again in an independent publication by other authors in 2014, they had the exact same conclusion, that vitamin D deficiency is a common problem worldwide. And very interestingly, we see vitamin D deficiency not only among the general population and among patients, but also among medical doctors. Here's an article published by the International Osteoporosis Foundation in 2015 showing vitamin D deficiency among physicians. 95% of hospital-based physicians have vitamin D deficiency, consistent with depression, immunosuppression, and chronic pain, whereas 89% of free-range physicians outside of the hospital also have vitamin D deficiency. Not surprisingly, latitude is mostly irrelevant for people working long hours indoors. Again, this is a global international problem among physicians. Let's look at another study that had the same conclusion. Vitamin D levels and deficiency with different occupations. This was published in BMC Public Health in 2017. They found here rates of severe vitamin D deficiency among healthcare professionals, medical students 72%, medical residents 65%, practicing physicians 46%, other healthcare employees 44%, and nurses 43%. So again, this is a worldwide, population-wide problem in the general public, among patients, and among healthcare providers, especially those who work long hours in hospitals. So because this is an important problem and it's a prevalent problem, that makes it an urgent problem. So we need to update and refresh our perception and paradigms regarding vitamin D deficiency in adults. For patients in pain, every day is urgent. For patients with depression, every day is important, and for patients with acute infections and immune suppression due to vitamin D deficiency, every day can, at times, be an emergency. But again here, in part 1, I'm focusing on chronic pain conditions attributed to vitamin D deficiency, and I'll show you the mechanisms in just a moment. One of the things I noticed when I was doing the first draft of this video is that having studied the pharmacology of pain management, I noticed that vitamin D doesn't even get mentioned in textbooks on medical pain management, and that's because most of those textbooks mostly talk about pharmacologic approaches, and they divide pain into two different categories, nociceptive pain and neuropathic pain. Well, vitamin D isn't either one of those. So my point with this slide from my other presentation is that the entire medical model is based on the pharmacology of pain management, not the pathophysiology of pain itself. So that was very important. Let me see if I can say that again. The entire medical model of pain management is based on the interventions that they use, drugs, surgeries, procedures, and those drugs address two categories of pain, nociceptive pain and neuropathic pain. The pain that we see with vitamin D deficiency is not nociceptive and it's not neuropathic, and I think that because the paradigm is inaccurate, I think that's why a lot of medical physicians have a hard time integrating the idea that vitamin D deficiency could cause pain. Because the way that most medical physicians are taught to manage pain is to look at it from a nociceptive perspective